Hi, we're here with Dr. Corey Campbell of the Motion Palpation Institute. And Corey, you've had a pretty tremendous background of working in multidisciplinary settings, and you've worked at a hospital as part of your practice. And go ahead and give us a little bit of understanding of how that looked and how you pursued that route and how it came to fruition in terms of working in that setting.
Well, I originally was in a private practice, and I was contacted by one of the orthopedic surgeons that I worked with that they were possibly interested in having a DC in their practice. It was something that they'd never had before. So I actually had to contact their office administrator and their kind of their practice manager as well, and I had an interview with them. And then I actually had to do a question and answer in front of 8 orthopedic spine surgeons and 2 physiatrists about how my treatment methods would mesh with theirs and what kind of referrals they would get versus I also worked with physical therapists, so they had both PTs, physiatry, and DCs, or one DC myself, underneath the same roof. So I went the complete functional route and told them that, you know, you guys can handle the structural problems, and I would be the functional guy. That would be also a direct access, which is a big. It's important for those guys to have somebody that's direct access. They don't need referrals from doctors for PTs and those kinds of things, and we can build your own practice. And once they saw that I was a secondary revenue source and was not totally philosophy driven by any means and was more down the evidence-based route, they were more acceptable to having me in there.
Yeah. How did that work? Was it a successful venture?
It was. I was there for 7 years. They joined a hospital. They became part of a hospital, so I had hospital rights, so I could go in. I never really treated anybody in the hospital. I went there a few times and did some grand rounds. But it was a successful venture. We got together 3 times a month, and we had indication conferences where we'd present cases. I would bring in videos. They would throw up MRIs. So it was a little bit of the 2 ends of the spectrum. But it worked well. I built my practice basically as a referral network from family practices that would refer into me, and then I would be more their triage doc, which is what they were kind of looking for. And I think DCs are definitely, we're definitely in that realm where we can actually assess people very thoroughly and know how to triage those patients out. And that was the main role that I played basically the last 3 years.
And we're seeing that a more common trend where chiropractors are being integrated into a multidisciplinary setting or in a hospital-based setting. What would you say for those young doctors who are coming out of school and maybe thinking about that as being their first step into practice? How do you recommend that they pursue doing something like that?
Well, the way that I've had a few docs that have done that, a few students that have gone out and actually gone into that setting. It's very difficult because most of those places like a little bit of experience, but it's important that you are confident in your skill set and that you have a very solid skill set coming out of school to begin with. And also having not only a good skill set from a palpation and adjust standpoint, but have a few other certifications coming out of school. Maybe a soft tissue technique or some sort of rehab background, because that's what they like to see. You have to contact the administrator of the facility. That's really the gateway to getting into those places. You have to talk to them, and then if you can get in front of the doctors that way, you have a better chance of actually making an impression. But the gatekeeper is always the administrator, so that's the person that you should contact for those facilities, not the docs themselves.
So you've had some pretty tremendous experience working in that setting, and it kind of facilitated the referral network as it was, but what would you recommend to doctors who are trying to build up their referral network and they want to network with orthopedic surgeons, physiatrists, some of those professionals? How do they start those relationships, and what are some of the steps that you found that help foster good relationships and communication?
And I have a very strong referral practice now, so I see a lot of referrals from the physiatrists and the orthopedic surgeons. What I would tell young docs that are looking to build a referral network is to, if you have a mutual patient, give a solid report of findings that's very concise and brief and not too overly long. And also keep it relatively simple, but not so simple that it's dumb. docs just want to see what your treatment plan is, what the primary issues are that you're treating. Send that out to those docs, and then if you can, give them a call. Pick up the phone and ask them what their plan is with those patients, and ask if you can bring in a lunch, or ask if you can go shadow. For the orthopedic surgeons and the physiatrists, they love to have people in there kind of watching and seeing what they do. They like to show off a little bit. So if you can go follow them around for a half a day, then you have a captive audience. You can actually sit there and ask them questions. Eventually they'll come around and ask you what you do. I typically don't talk about what I do until I'm asked, but I ask them a lot of questions and try to develop a relationship that way. So I would start by a solid report of findings, a phone call, see if you can take a lunch into their entire facility, and then also shadow them, because it's all about building personal relationships. So my top 5 referrals are also guys that I could go out and have a beer with if I wanted to. So it's about developing relationships.
So let's walk through the process of taking this to the practical level. If a doctor is looking to form one of those relationships, like you said, a really strong report is a great way to do that. Communication and just picking up the phone and saying, hey, I have a patient that I'd like to talk to you about. And that's a good way to interact with them. But then doing a lunch, why don't you tell us how you've done that in the past, because that can definitely be a successful way of marketing.
Yeah, so after I've talked to the doctor, or I've picked up the phone, typically before I hang up, I ask him, who the office manager is or who the HR person is that I'd contact, and they usually give me that phone number. And so we call the HR department, and we ask them if it'd be okay if we brought in a lunch for the whole staff, not just the doctor. So for $100, you can feed 12 people pretty easily. We just ask to bring in a lunch. We set up a time and a date, and we ask them if there's any food allergies, how many people, those kinds of things. We just take in a lunch. And a lot of times you get more referrals from the nurses and the front desk people. That's where you really generate referrals from, is from that front desk setting. So we take in the lunch, and we just talk to the docs. We keep it very casual. We don't do formal presentations. Sometimes we take in a few handouts or a few flyers that tells them what we do. And we just interact with the staff. And then we usually have a follow-up, like in 2 weeks, we have a follow-up letter to the docs, and then we take in a small breakfast for just the front desk staff.
That's
just
great.
a breakfast tray.
Hey, they're the gatekeepers. You have to butter them up. No, that's good. And that is a great way to build those good connections. So Corey, one of the questions that we oftentimes ask people, because I think this is something we've all experienced at one time in our practice, is how to deal with an angry patient. I mean, they're going to come through, and despite our best efforts, I mean, it could be that they're having a bad day. They might be having something going on at home, or else they're just like sick and tired of the pain that they're in. So what are some suggestions that you can give for dealing with a patient that's really angry?
For me, I mean, I've seen that before in the multidisciplinary setting. Patients that are central pain patients, they're on spine stimulators, they're on methadone for the pain. They can be very irritated. The biggest thing with those patients is taking the time to show that you actually care about what's going on. I ask them a lot of questions. You have to actually communicate every single thing you're going to do. If you're going to do any manual therapy work on them, tell them what you're going to do, and then ask them if that's okay, if that's something they think they can handle. Walk them through every single step that you're going to do, and just show them a ton of compassion. And maybe you don't even treat them that day. Maybe you just talk to them and try to figure out, what it is that's making them so irritated. So for the most part, for me, it's just a lot of communication and just showing them compassion. And
sometimes even follow up after the appointment too. I've found that that's a great way.
You always need to give them a phone call at least the next day.
No, that's really helpful. And so again, Corey, we appreciate your time here today, and we really appreciate you doing the course with us. Thanks a lot.
Hi, I'm Dr. Mark King from the Motion Palpation Institute, and I'm here with Dr. Corey Campbell, a board member from the Motion Palpation Institute, and we're going to just ask a few questions and get his opinion on some things. I wanted to start with what equipment do you need to get started with your rehab at your office?
Well, the nice thing about the upper and lower dynamic classes we teach and how to incorporate this into a practice is really it's low-tech rehab, so you don't really need a lot of equipment. You need a Thule board, you need some TheraBands, some loops, a few exercise balls, and some foam rollers. Really, that's all you need to get started with some of the concepts that you saw in the upper and lower dynamic classes. So it's very simple. It's low cost. You can probably start up for under $200 and have more than enough.
It's more about the information and teaching than it is about the equipment.
Right.
So I think that helps a lot of the young docs out there when they think about adding this to their practice. So another question I have is, you have this new information that you just went over in these classes. Where do you start with this information on Monday morning when the doctor goes back to his office?
Well, that's a question we get a lot. How do I incorporate this into a practice Monday morning? And the big thing I tell my students and docs is that it can be so overwhelming. There's so much material in these classes that you need to just pick the 3 or 4 things that you like the most and just give yourself a solid month of focused intensity where you just work on those 3 or 4 things. What I typically tell them is to get a hold of the functional eval form, go through 3 or 4 of the screens that you want for the upper and 3 or 4 of the screens that you want for the lower, and only do those 4 screens initially in your initial eval. If you already have a system in place, maybe you only take 2 of those tests and you work and train your eyes on those 2 tests, and then the associated soft tissue techniques and the associated rehab with those areas, but only do 1 or 2 of the exercises and only do 1 or 2 of the techniques with soft tissue, and just do that for a solid month. The other thing I tell my students and docs is that if you take that eval form and you take a highlighter after you've gone all the way through and the patient is gone, you take a highlighter and you highlight the big findings on those exams and only work on the concepts that are in those highlighted sections, it makes your treatments a lot more concise, and you can get it done in 15 minutes, easy, and so you can incorporate it into a busy practice.
So I know you have a busy clinic, and a lot of the doctors watching this have a busy clinic. So a lot of the things you just said will apply to this next question, which is, I have a busy clinic. How do I incorporate this information into my busy clinic? I haven't been doing rehab perhaps in the past. How do I make this work?
Well, you have a couple options. First of all, you have to do it yourself. You can't teach somebody else to do the rehab unless you completely understand how to do the exercises in the rehab. And you can't teach somebody the technique on, say, a post-isometric relaxation technique until you've done it yourself. So again, take those 1 or 2 concepts that you like the most that you can fit into your current practice system or your current practice schedule, and just work on those for a month or so. Give yourself time. Now, the other thing is that we get students and docs that put so much pressure on themselves. They want to try to throw all of these things in at once, or they want to try to do all this stuff on a patient at one time. As a system of checks and balances, if the patient is worse off after their treatment session, you've probably done too much. You need to peel back and just do less, but just focus more on the techniques that you've chosen or the concepts that you've chosen to work on. It's a marathon. It's not a sprint. Just take your time. I've been in practice for just a little over 10 years now, and I'm constantly adding and changing things and taking things out and putting things in that are just more efficient and work better for me in my setting. So you have to literally just give yourself time and don't worry about trying to cram all of this into busy practice right away. Take the notes that you have in front of you from the classes and circle the section that you want to work on for, say, March, and just work on that section and just try to really master that before you move on to the next thing. It just makes it so much more easy to incorporate and digest, and it makes it more palatable for you as a doc, especially if you're a linear thinker.
Right, this idea we often say to young students, our classes are often like drinking water from a fire hose. We often joke about that because the information is overwhelming, but with repetition, you do get it. So bite-sized chunks is where you would tell them to start and not try to do the whole thing all at one time.
Yeah, absolutely. And develop your own system. What works for me and what works for Mark or Brett may not work for you. So write it out, have some goals in mind, write those out, and then write out in a list what you want to accomplish that month or that week, and take it that way. Just take it slow. You can't put all of this in at once. It's just too much to try to do.
I want to add, for the people that know me out there, I'm very much obsessed with systems, and I always want to have a system in place. So this is another example of, you have to have a system like you're describing so you can learn this adequately, learn some of it well, and then keep adding to it. And one of the big things I want to reemphasize of what you said is, don't try and jump to the advanced exercises right out of the chute. You're better off doing the lower level exercises really well and advancing slowly with your patient. You don't have to, not all your patients are Olympic athletes that can jump to the front of the line. You have to do some of the low level stuff and make sure they're getting that right from the beginning. Now this next question is actually kind of a 2-part question, but what are some other resources for the docs and students out there watching who want to learn more about rehab? And then for you, who have been some of your mentors in learning this information?
Well, I mean, not to pump MPI too much, but we have a great reading list on our website. If you go to the website, we have a reference list. You can go there. There's clinical books there. That's a great place to start. Just pick one or two of those books again and kind of go through it and work through some of the concepts. But there's so many classes out there. It's easy to kind of get lost in the mix, but there are some really excellent classes that you can take either through National University has some good rehab classes that come through. Check out the Central Institute of Human Performance in St. Louis. They have some good weekend classes that come through. And then the UDMA classes and the LDMA class that the MPI offers is a good overview of some places where you can also get some more reference materials. And as far as my mentors, I've had a lot of really good influences. I've been very fortunate and very lucky to have been trained by some of the best in the world. But if I were to pick a big three, I would definitely say that, and it's not because he's sitting next to me, but Dr. King has been a huge influence and a big mentor for me, just from a practical standpoint and from a learning standpoint. Pavel Kolaj has been a big influence in what I've done, and just his humbleness and the way that he's still one of the best in the world, but very humble, is another big influence for me. Those are probably the biggest two, and then the combination of Professor Levitt and McGill, and although I never really learned directly from Professor Yonda, those combination of people and their concepts and their teaching styles and what they've brought to the manual therapy world have definitely formed a lot of what I've done. And Annie O'Connor from the Rehab Institute of Chicago, her passion for teaching and her passion for patient care has also influenced the way I approach my patients. So those are probably my biggest mentors.
Well, thank you for the kind words and thank you for your information.